duty. And so OPL always rocks. This is the climax of the whole conference. Thank you very much, everybody. So I will be showing two cases. This is Mumbai, but I get my superpowers. I can stop hard rockets with one hand. So this is the operation theater. As you can see over here, and these are the cataracts that we are faced with every day, and now even more so because of the delay in the surgery because of the COVID. As you can see over here, the rhexis is difficult because of the calcified capsule, and you feel that the struggle is over and you are doing it, but with a forceps, with a capsulotomy needle. As you can see over here, that there is no support for the nucleus or the epinuclear buttress, and there is no followability, and the phaco tip does not hold the nucleus. There is deepening of the iris lens diaphragm, as you can see over here, and it is dancing, it is fluctuating. The pupil constricts, and it is very difficult. The anterior chamber is not as stable as it should be. And of course, as a surgeon, I'm quite tense because I'm worried about the patient's safety and giving him good vision back, which is very, very important to all of us. I continue with my phaco, and as you can see over here, I'm not getting a grip to even get the two divisions or to make a proper first division. And I finally get a grip, and there are lots of ways that it can be managed. As you can see over here, the chamber is not stable, and hence maybe the inflow rate is very large. So you reduce it, and then you try to do a chop technique. There is no epinuclear buttress, and that's how the lens, rocks. You can also use an AC maintainer if you have any problems, or you can extend the rhexis, because the rhexis was so small and the amount of fluid that was inside the bag was very large, and that was creating the problem. The second patient is a patient of a small pupil, as you can see over here. And why do you face such complicated cases every day? Yes, we do, because we operate at Baba Amte's ashrams. And do these patients ever see? You have to make it a point to make them see. All of us, including me and you, we make this effort. As you can see, this is a leprosy patient, and you can see the hand of the patient. We have spent a lot of time at Baba Amte's ashram, and this is what they have. The sclera is very, very thin. So if you have to be very careful while making an incision, because otherwise you go through and through. Though it appears to be very thin, it's very, very fibrosed. So if you try to do a cataract surgery, you may have the whole iris in your hand. The corneal opacity is because of the neurotrophic cornea. So the posterior synechae are broken. It is not only at the edge of the pupil that there are posterior synechae. It's like the whole lens is plastered to the posterior surface of the iris. And because of the previous inflammation, as you can see over here, the iris, when you touch it, bleeds. You have no choice but to expand the pupil and then to remove a lens. We did SICS because there was no other way to tackle this patient. But the patient had to see, because the patient was blind and he needed to work and work for his livelihood, or at least to look after himself, because most of these patients are abandoned by their families. And then an intraocular lens was put. Now, this is a video of a patient before I saw Amar sir doing a wonderful pupilloplasty. And I wish that time I could have done a pupilloplasty too for this patient to get a good pinhole vision. These patients definitely do get a good vision, and it is dedicated to all the leprosy patients, and someone who devoted all his life for the leprosy patient. We got a chance to work with him and work at the leprosy ashram, and we continue to do so. And I really thank Amar sir for this opportunity and for teaching us so many different techniques, and everybody present here today for such wonderful videos and for a great conference. Thank you.